Welcome to the Strokecast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
Hello, I'm Bill Monroe, and welcome to episode 39 of the Strokecast. This week's episode, Fanning the Flame of Recovery. Our favorite neurologist is back. This week, Dr. Nirav Shah and I talk about antidepressants, SSRIs specifically, in stroke recovery. The FLAME study demonstrated the benefits to motor recovery of SSRIs. Similar results are coming out of other small studies as well, and so this is some pretty exciting stuff. SSRI stands for Selective Serotonin Re-uptake Inhibitor. Basically, the way data gets sent from one nerve cell to another is through the use of chemicals like serotonin. The body produces serotonin and collects it when it's done using it, taking it out of the system. An SSRI prevents all of it from being collected, leaving more serotonin floating around the brain. Having more serotonin floating around the brain can help reduce, manage, or eliminate depression and other conditions. That's why SSRIs are some of the most common antidepressants on the market. It also seems that the extra serotonin may help promote neuroplasticity and recovery of motor skills after stroke. And that's why we're talking about it today. When I was inpatient, the doctor put me on an SSRI due to the FLAME study. She tried Prozac, also known as Fluoxetine, for which the study is named, first. Unfortunately, it gave me an anxiety attack. On the other hand, I now know what an anxiety attack feels like. And yeah, it's not pleasant. A Xanax took care of that one. The next day, we tried again, this time with Lexapro, also known as escitalopram. Someone explained to me that the molecule that makes up Lexapro is the mirror image of the Prozac molecule, so it will probably work pretty much the same. I'd had Lexapro in the past with no ill effects, so it was worth a shot. And success! No anxiety attack this time. And that's how an SSRI earned a spot in my daily collection of medication. But did it help with my recovery? Maybe. There's really no way to be sure. The data indicates that it should, and there's no reason to think that it didn't help. And of course, as a side effect, I did not go into the deep depression so common among many stroke survivors. Of course, this is a new use for SSRIs. Not all doctors are familiar with the idea that SSRIs promote the neuroplasticity that supports the recovery of motor functions. And that's how I ended up explaining the research to my primary care physician as he reviewed my meds with me post-hospital. The FLAME study covered about 6 months, and I'm still taking Lexapro today, more than 14 months post-stroke. When I talked to my rehab doctor about whether or not it makes sense to continue, what we concluded is that since I don't have any negative results from it, we may as well keep it up. If there's a chance it can help and it's not hurting, well, that sounds good to me. I do have links to the FLAME study and some of the other research being done around SSRIs in the show notes, so be sure to check out strokecast.com/flame for more details. If this is your first time listening to an episode featuring Nirav, it may be helpful to know that Dr. Nirav Shah is a fellowship-trained neurologist and subspecialist in cerebrovascular and stroke medicine with board certifications in neurology, stroke medicine, carotid neurosonology, transcranial Doppler ultrasound, and neuroimaging. He's a practicing neurohospitalist and served as the stroke medical director at Swedish Medical Center in Seattle. Academically, he's interested in emergent and critical care neurology research and is an associate editor for the Neurohospitalist, a peer-reviewed journal. He enjoys mentoring trainees and collaborating on publications and conference presentations. Outside of clinical care, Dr. Shah is collaborating with experts to develop scalable technologies capable of ameliorating healthcare's challenges. He consults with startups and investors to develop technologies and devices so that one day they are available to his patients. He's worked with companies to meet FDA regulations for approval, as well as help them understand the provider perspective of product market fit. Dr. Shah is also the CEO and founder of Sentinel Healthcare. He is a passionate traveler and photographer. So let's fan the flame of recovery with Nirav. So Nirav, welcome back to Strokecast once again.
Thanks for having me.
I am thrilled to be here and talking about this element of research, which I have found is really interesting, and personally I've ended up having to educate some of my own physicians about because they haven't encountered it, and they asked me why I was taking an SSRI after my stroke. And that is the FLAME study. And we normally think of SSRIs, when most people have heard about them, is that they're antidepressants. So that's what most people think they're used for, but they're also being used for stroke recovery. So could you talk a little bit about that?
Yeah, so to kind of go quickly into just the basics of these medications, things like Prozac, Zoloft, which are the brand names for medicines like Fluoxetine, Duloxetine, or others, Cymbalta, these are medicines designed for depression, and the SSRI stands for Selective Serotonin Re-uptake Inhibitor. And what that means is between two neuronal synapses, where neurons connect to each other as a synapse, these medicines help keep serotonin around longer and prevent them from getting recycled faster.
So when we talk about the synapse, that's actually, cells don't actually physically connect with one another, is my understanding. There's a space between them, and they use chemicals to send messages back and forth.
That's correct. That's correct. And serotonin is one of the transmitters in the brain. It's also one of the transmitters that is clearly associated with depression. And so these drugs have been really great at helping depression and helping people manage depression. And so the role that they have in stroke is somewhat unexpected, but came out of the lab, like many projects that we talk about do. And it was found that this class of medications, when given to a mouse or a rat, could improve the recovery that they would have in a controlled setting of stroke, which eventually led its way to a patient in the study FLAME. And so FLAME was a study that was focused on motor recovery specifically. We can talk about all sorts of recovery, visual recovery, visual, spatial, motor, and language. And this was focused on motor just because it's an easier thing to study.
Sure.
And so what they did was they took about 118 patients, randomized them. Some got placebo, some got fluoxetine, which is an SSRI. And interestingly, the patients were randomized in this way. The ones who got fluoxetine actually were sicker. They were a little bit older. They'd had more history of stroke, and their stroke severity at baseline when they were enrolled into the study was worse. So that is even more interesting when we get to the results of a study like this and find that these people actually did better than the people who didn't get the fluoxetine at 90 days.
So they were, after the study, the people who started off worse were actually better than the other folks.
And so that's the amazing potential finding in the study. It made headlines in Lancet Neurology, which is a major journal. And now then the question becomes, do we do this as part of our regular stroke care? This study was small. It had some limitations. It wasn't designed for this. Again, it was a simple single-blinded study rather. Actually, it was double-blinded, and it demonstrated something really interesting. But it's also possible that people who've lost more have more to gain. So we could have the discussion that maybe because they enrolled sicker people, these people improved more because they were already on the path to recovery, and so it just looked better on statistics. I don't think that's true, but that's one of the considerations that we'd have to think about statistically. The other good thing about the study was almost no one had negative adverse consequences. About 17 people in the placebo arm had depression, 4 in the fluoxetine arm had depression out of the 59 in both. And so at a minimum, it prevented post-stroke depression, which in and of itself is a huge problem. And is probably one of the reasons why many people may not have the desire to even participate actively in therapy. And so we then kind of come full circle. Well, what are we treating? Are we actually improving the recovery at the brain, neuronal, kind of cellular level? Or are we just helping people be more engaged so that they're in a better mood and therefore more participatory with their recovery? The answer is probably a little bit of both. The reason why we suspect as a community that it's not just mood creating a desire or more effort in rehabilitation is that the effects are seen pretty earlier than they are than when we would see with depression. So within the first few days, there seem to be some effects when we look at the studies and kind of the tracking that they do. Nonetheless, these are the controversies and some of the kind of balancing nuances that have led themselves to the next set of studies, which are mostly coming from Europe. And the one that is expected to complete next year is called the EFFECT study, which is another SSRI. You might wonder why it's taken so long for these studies to come to the world, and when we've had SSRIs for depression since the 90s, why are we now only starting to have these studies even be done? The answer is probably because there's no money in it, right? As many things, it's always about the money. And so once these drugs became generic, there is no real incentive for the pharmaceutical companies to do the study for these drugs. Perhaps had we found this earlier, maybe a decade earlier, and had been found a little bit sooner, the pharmaceutical studies, companies themselves, I should say, would have been much more incentivized to fund and develop these studies. However, in this case, the UK and other countries are funding the studies from government grant funding. So the good news is that these studies that are going to be coming from Europe are not funded by industry, which many people have concerns about. These will be third-party, governmental, not biased in any way. And the medications will also be cheap when and if they're given to stroke patients, specifically for recovery.
Right. So it sounds like it's one of those things where it's really hitting, today at least, a really promising combination of an inexpensive treatment that appears to be effective, but doesn't appear to have a significant downside, and has the added benefit of minimizing the risk of post-stroke depression, which causes so many other problems. So it seems like it's one of those where it's a low risk, high potential reward, and that seems like a winning scenario in general.
That's correct. Yeah, I agree too. I mean, I'm really excited about this becoming prime time, or at least us having the data to decide, mainly because many of us in the stroke community prescribe it anyway, off-label, because the benefits are so much greater than the harms, especially in the setting of stroke. So, and it's not even quite off-label. I mean, if someone tells us that they're not feeling great, they're apathetic, they're not with great mood, they already might meet the criteria for depression. And so we would have a discussion with them and offer it. And sometimes we know that people of certain backgrounds aren't interested in antidepressants, that they'll, I've had patients say, I'll man up and I'll just get through it, right? And there are different cultures who are more susceptible to that than others, or different people of different backgrounds. So one nice way for us to kind of explain this to people is, well, what if I told you I had something that helps two problems? Maybe gives you a chance for recovery and the potential for helping with your mood. Oftentimes that works for patients because there's a big resistance, we found sometimes, to take more meds, and we understand that.
Sure.
So we always want to do the right thing and balance that, but it's nice to be able to offer it. And patients in general, in my experience when I've seen them in the clinic, really appreciate it. They want to stay on it.
Yeah, it's one of those things where you see sort of this dichotomy, it seems, in stroke patients, where it's like, well, what's one more pill in my daily pill organizer, versus folks who want to get down to eliminate as many of them as possible. And I also think that like that idea of having that dual purpose behind the medication gives somebody an excuse to take something they might have been reluctant to otherwise.
Yeah.
Also, I think what strikes me is it's like the idea too, and I have no idea if this is the mechanism behind it, but just the idea of having that extra seems like it's just the idea of having that extra serotonin floating around in the brain may be what helps promote the neuroplasticity and the regrowth for the recoveries.
I think that's the idea. I mean, what's confusing to us is, as a community in the neuroscience community and clinical neurologists, is why would something global like this make such a targeted difference? Because in some cases we know that too much of serotonin can also be bad. And so it's a little bit confusing because different contexts have different benefits. The other interesting thing we can talk about briefly is it's not just motor. The really exciting news from this year from Hopkins in South Carolina is a study where they looked at people who just happened to be on SSRIs and who had language loss, aphasia, the inability to express or to name or to repeat. And what they found is people who had serotonin reuptake inhibitors, SSRIs, prior to their stroke and took them for the next few months, they actually had more recovery of the regions that were affected and associated with language. In this study's case, it was the left posterior superior temporal gyrus and the longitudinal fasciculus and the arcuate fasciculus, two specific regions associated with language. And then they did a follow-up study where they tested individuals with stroke in the left hemisphere, where language usually affected, and found that it actually did make an impact in people who had a stroke, who had language loss, and who were then given an SSRI. And so I think now that we're starting to put these threads together, we're going to find that this is not just a motor recovery treatment alone, that this can help people with aphasia, and then maybe people who have visual and spatial issues as well from a parietal stroke or an occipital stroke. So I think the exciting part about where this field is heading is we'll have enough data hopefully to say this is just one part of the regimen that will help you recover.
And one of the things that I think is really interesting as we talk about these studies, and a few weeks back when we talked about the stem cell stuff, is that a lot of times we see headlines about these amazing results and these things that are super exciting and super promising. And what really comes out of these discussions, though, is that, yes, this stuff is, when we say something is really promising to a researcher, to a neurologist, that doesn't necessarily mean the same thing the general public does. All of this stuff has caveats and limitations and aspects of the study, and there's so many footnotes to it that actually tell the real story.
That's correct. I mean, one of the caveats to this whole SSRI story in the setting of stroke is that there's reasonably good evidence that using an antidepressant of any kind, SSRI, SNRI, dopamine reuptake inhibitor as well, could potentially increase the risk of microbleeds, which are tiny 1 millimeter, 2 millimeter little bleeding, bruising, hemorrhaging, which is the other balance, right? We don't want to increase the recovery of stroke only to give people bleeding risk.
Right.
And that's the dilemma that we're going to eventually have to balance across the board, because we're now starting to understand the impact of microbleeds. We probably should have a follow-up just to talk about microbleeds, because it's actually becoming a big controversy for us as well as we start thinking about the impact that we're seeing to the brain long term. Microbleeds are something that we didn't even know about really to speak of 20, 30 years ago. We're finding them now more because we're having better MRI technology. And the magnet in the M in MRI can induce susceptibility in breakdown products of blood, which is iron. And so when iron's broken in a bled state, I should say, in a microbleed, we can now see that. And it creates what we know as blooming artifact on a specific type of MRI. And so when we see people who have this, we now know that they have some risk of bleeding. And the issue is the better the MRIs get, the more of these we see, even though they're very, very small. And so we're starting to have to try and identify how are we going to balance all of these considerations as we learn more.
Right, and then throw in the whole ischemic versus hemorrhagic stroke.
Yeah.
And whether or not somebody's had an TB probably means you don't want to increase any of the bleed risk for a time. And it's all a very complicated type of thing. And that's why it's so important to get to the hospital as quickly as possible and get the
Exactly.
professional care. Well, Nirav, thank you so much for joining us this week. And I know I've learned a lot. Look forward to talking with you in the future about microbleeds and other neurotech.
Yeah, I'm excited. Thanks for having me.
And that brings us to our hack of the week. Leave your pillbox open. I actually picked up this tip from my girlfriend in how she manages her assorted medications. A lot of us now have multiple pills to take, and to try and keep track of them, we use one of those day of the week pill boxes where we sort everything at once and get our by day pill selections ready to go. For folks with memory challenges or just folks who just tend to forget stuff, we sometimes have to step back and think, did I take my pills today? One way to manage this is to take your pills and then leave the door for that day open. So for example, on Tuesday, once you take your pills for Tuesday, you don't close the little pill door for Tuesday. You leave it open. That gives you a visual cue for the rest of the day that you already took those pills. And it also helps remind your caregiver that you already took those pills. And of course, if you or your caregiver notice that it's actually Thursday and the only open pillbox lid is the Tuesday lid, then you know you've got to go ahead and take those pills because you haven't taken Thursday's pills yet and possibly haven't taken Wednesday's yet. So simply leaving the most recently emptied cell of your pill container open gives you important data and is a really simple memory trick to help you keep track of whether or not you've taken your pills. So that's it for this week. If you like scientific reports, be sure to check out the links to the SSRI studies at strokecast.com/flame. Make sure you subscribe to Strokecast for free in your favorite podcast app. Use your pillbox as a memory tracker and calendar. And of course, as always, don't get best, get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you next week.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The Strokecast is a proud production of the Currently Speaking Podcast Network.